Hello everyone, it's an honor to welcome you all here. So please share in the chat box where are you watching this webinar from. We will be starting our webinar in 7 minutes from now, and I hope you will really like it. It's a wonderful talk, and I think it's very futuristic as well. Many of us know that there's a lot of growing interest in robotics. That's kind of an interesting topic for all of us. So please do write your comments and your questions in the chat box. I will be happy to take them up by the end of the session. So I hope you will really like the session as well. If there's any topic you wish me to organize a webinar on, please feel free to message me or you can put it in the comment box, in the chat box, that I will be happy to take them up. So please share in the chat box where are you watching our webinar from. We will be starting in 6 minutes from now. So hello everyone, thank you very much for joining us. I'm seeing that many of you are. Oh, that's great. That's wonderful. Greetings to Ghana. Oh, greetings to Dr. Abdullah. Yes, Lahore is my hometown. I've been trained at Pins Lahore. It's a great honor to see anyone from Lahore. It's my hometown. It's amazing. Welcome. We will be starting in 5 minutes from now, and please do write your questions and your comments in the chat box, and we will be, we will take them up by the end of the session during the Q&A. There will be a brief session of discussion, and the discussion and the Q&A session, and I hope you've been following the updates in my news channel. You can you can join any of my WhatsApp groups, or you can follow any of my social media account. The news page on Facebook is quite active. You can follow my page to get all those updates, and also please subscribe to my YouTube channel to gain access to many of the recordings that I have been keeping lately. And I believe that you all know that I have just started a comic series, a neurosurgical comic series known as Neuromics. The first book of the series is already available on Amazon, and it's also available in Kindle. If you are a Kindle Unlimited subscriber, you will be able to read it for free. So I'm happy that you can access it on Amazon. And I believe that many of you already have the link to see the book, and I'm also adding 3 to 4 books in the same Neuromics, the neurosurgical comic series. So they will be available quite soon, inshallah, I believe, by the end of the month or so. So it's a bit lengthy, and it's a bit hectic to generate all those graphics, because you have to be very careful about sharing those, and making those, creating those are very accurate. And also there is another book that I'm working on currently. This is with Professor Luis Borba, and basically a prequel to the book we have already published to the Paramount Publishers in Pakistan. It's available in Pakistan and also available for worldwide delivery, and you can WhatsApp the publisher and ask them to deliver it in your country. And this time it is known as the Neurosurgical Approaches Recall, and just considered a prequel of the Neurosurgical Approaches that I was able to publish with Professor Luis Borba. And yeah, I believe that you will like that book, because it is now giving you another perspective, and it will be especially very useful for the trainees who have just started. it. So I believe that you will certainly enjoy it. And this is the link of my neuromics book, the neurosurgical comics, and these are available on Amazon for worldwide delivery. And you can, if you have a Kindle, you are a Kindle user, you can also download its Kindle, or if you are a Kindle Unlimited subscriber, you can access it for free. So I believe that you will like it. I will be really happy to look for your comments and your suggestions on the Neuromic books. And I see that many of my colleagues actually pre-ordered it, and they sent me wonderful pictures with the book, and I was really happy to see, and I was really happy to see your very wonderful comments and very wonderful feedback. So I'm working on more of those neuromics, and I hope that you will love those neuromics as well. But there is another book that you will certainly appreciate. I'm sure you will appreciate, and it will be available real soon. I will be sharing a little teaser about it. I've been working on it lately, and also, I'm publishing flashcards at the Neurosurgical Recall book with Professor Luis Porba, and it will be available by the end of the year. It's a long work all the time. Like everyone says, that publishing a book is basically something a little difficult, you may say. So it takes a little longer than you have been planning. So I believe that you certainly like it. So if you have any topic in your mind that you wish me to arrange a webinar on, please share it in the chat box, and I will be really happy to talk about it and to generate something on it. And welcome, Dr. Harshad Parekh. It's an honor to see you again today. Thanks for joining. Dr. Harshad Parekh is. Hello,
Hi,
sir.
hi, how are you?
I'm doing great. How are you doing?
I'm fine. All okay.
What? That's great, sir. I'm so happy to see you. Thank you very much for joining today.
Always it is my pleasure to learn from you people.
No, no, it's a pleasure to welcome you all the time because
Thank
you are
you.
a
That
wonderful.
is very nice of you, but we learn a lot from your lectures.
Oh, really? That's great, sir. That's
Yes,
great,
yes.
sir.
Yeah. We
Sir,
are here to learn more rather than teach more.
it's a continuous process. I believe that all those teachers like you, they always say that they
Mm.
learn more from other teachers, and I think this is a very continuous process. And I'm so happy. I'm so lucky to be a part of this educational initiative. So I'm so happy to have you all here. I'm really grateful to your support.
Thank you very much. We will be always there to learn something.
It's great because all of you just share your ideas as well. That that makes the session really insightful and enriching because everyone has his or her own experiences with the same thing, and it's really good to have you.
Thank you. Thank you. Looking forward to learn.
Thank you very very much, sir. I think Dr. Bydon is here. Hello, sir.
Good morning.
Good morning,
So,
sir.
sorry, I had to restart my computer. Some technical difficulties.
No, no, no problem, sir. I'm really sorry. I knew that. So thank you very much for joining us today. I know you have a very busy schedule, so it's a matter of real honor for us to have this opportunity to listen to you. I've been a big fan of all your wonderful work that you've been sharing. You've been inspiring, neurosurgeons from all around the world. So it's a pleasure to see you here today with us.
The pleasure is mine. It's very nice to be with you. Thank you, Dr. Noor, for inviting me, and thank you, colleagues, for joining. It's a pleasure to be with everyone.
Thank you
I,
very much,
I
sir.
do. Oh, I
Yes,
do
sir.
have a slide deck that I can start to share if you'd
Sure,
like.
sure. The podium is all yours. I will just give a very brief introduction. Obviously, you don't need any introduction. Everyone knows you so well. And indeed, we were so excited to have you here with us. So, but for just so for formality, I will be happy to say a few words. It's an absolute privilege to welcome you, Professor Biden. You are a world-renowned leader in complex spine surgeries, spinal oncology, and minimally invasive robotic techniques, and it is huge and I've been really following all your wonderful lectures. The recordings are widely available on the internet for us, and it's a big, it's generosity of teachers like you that they share all their knowledge, their experience, and expertise with the world. So, for all of you, many of you, obviously, most of you know him so well, but Dr. Bydon served as the inaugural chair of the Department of Neurological Surgery and the enterprise neurosurgeon in chief at the University of Chicago, Medicine. He's a graduate of Dartmouth College and Yale Medical School. He completed his advanced neurosurgery and spine fellowship training at the Johns Hopkins Hospital, and he has worked for a huge amount of time in Mayo Clinic and has pioneered a lot of techniques and till now he has authored more than 600 peer-reviewed papers and has served as principal investigator on groundbreaking clinical trials utilizing stem cell therapies for spinal cord injuries. And please join me in giving a warm welcome to an extraordinary clinician, an innovator and educator who is truly shaping the future of organized neurosurgery. So, sir, it's a pleasure to have you with us today. It's a real honor to welcome you. The podium is all yours, and there is no time limit. It's a single speaker webinar. So please feel free to take your time and to deliver your wonderful lecture. Thank you very, very much for joining us today.
Thank you very much. It's a pleasure to be with you. I'll give you a lecture that's about 30 minutes, and then we'll be happy to take questions that you may have. And I assume that you're able to see my slides?
Exactly, so it's perfect.
Okay, great. So I'm Mohamad Bydon. I'm the Ramedi Chair of Neurological Surgery at the University of Chicago and the Wallman Professor of Neuroscience in the Wallman Society of Fellows. So it's a pleasure to be with you and to be able to share with you, some of the kinds of surgeries that I do. And so if you don't know the University of Chicago, Chicago's, a global city, the kind of the second city of America, if you will, a beautiful city for those of you who are interested in architecture, the home of the Pritzker Prize, which is the Nobel Prize of Architecture, and you'll notice that beauty throughout the city. And it's right on the lake. We call it a lake, although it looks like an ocean. You can't see the other side. And the University of Chicago is in the Hyde Park campus. We're on the same campus as the university, our medical center. Our medical center is about 6 million square feet or 600,000 square meters. And we are building now what will be the largest cancer center in the world, which will be done in about 5 months. It's almost complete. And you'll be able to see when you come. Our hospital is actually also an architectural landmark built by and designed by Raphael Vignoli. And you see many elements, if you know Vignoli, you'll see many elements of his design that frankly have been just wonderful additions. And we are a level 1 center of complex care and high acuity. And we're the teaching hospital for the Pritzker School of Medicine at the University of Chicago. So I'll tell you about my practice. I do spinal tumors. I do minimally invasive spine surgery. I do a lot of robotics. And I'll show you some examples. When it comes to spine tumors, obviously there's primary spine tumors, there's spinal cord and peripheral tumors. I do use MIS techniques when possible, and I use it when they offer advantages. And I'll give you sort of an example of that. I do also avoid fusions when possible. So with unilateral facetectomies and things of that nature, I do like to avoid fusions when that's feasible. This is an example of a 28-year-old with a left L5 schwannoma, which you can see here. And traditionally, this is a surgery that would be done anteriorly. But I think, what I've done with these now is a tubular approach, and I've done several of these with this approach. And you can drill the lateral facet. You can access the tumor very nicely, and you can do a very thorough resection of the tumor through a tubular approach. That's single surgeon that would avoid the need for access, that provides you with a very robust resection of the tumor, which you can see the post-op image on the right. And so that's an option that I think is appealing and something that I increasingly use in my practice. Minimally invasive surgeries in general have a number of principles behind them. The preservation of the muscles and the ligaments, in particular the multifidus muscle, particularly for extension, for posture. Don't be fooled by the x-ray. Sometimes people tell you about sagittal balance, but in the setting of stenosis, I've had so many patients that are forward, but after a laminectomy alone, they can stand straight. So a lot of the reason that they're forward is the spinal stenosis, not deformity. And it's important to differentiate that. Visualization, of course, there's microscope, endoscope visualization. Um, I try to avoid fusions when possible with arthroplasties, with minimally invasive decompressions. And obviously, there's a number of approaches that might be tubular, percutaneous, endoscopic. And those are, various things that I could show you and that we could discuss. In this case, a couple of cervical cases here. Um, this is a 42-year-old female with a left C7 radiculopathy. And you could see on the parasagittal image exactly what's causing that radiculopathy. You could see on the axial CT, where that left-sided radiculopathy is coming from. And so this is a case where if there's no movement on flexion extension, to me, and if there's no, frank instability, and this is not a case of significant pain either. And so this is more of a pure radiculopathy. This is a case to me where I think a foraminotomy makes a lot of sense. And so here's my preoperative imaging in terms of T2 MRI, sagittal and axial. And then here's my flexion extension imaging. And again, no pain, and there's no movement on flexion extension. And so in that kind of case, what I would offer would be a minimally invasive, tubular left C6-7 foraminotomy, which can be very successful, quick, rapid. Patient leaves very quickly and is very satisfied. Now, this is a patient with bilateral symptoms, a 44-year-old male with bilateral radiculopathy, failed non-operative measures, injections, PT, what have you. And so that's a different case to me because when it's bilateral, I generally wouldn't do bilateral foraminotomies in these cases. This is a case where I would lean towards a different kind of approach, like an arthroplasty. And so you can see here where I've removed the disc. You can see my arthroplasty exposure. And so I think an arthroplasty is great in this case. You don't have a lot of neck pain. The problem is not a facet problem. You've got bilateral radiculopathy, a young patient with well-preserved disc height. So I think this is a great case for an arthroplasty. An arthroplasty, I'll add, is a very well-studied procedure, one of the best studied procedures that we have in neurosurgery. And it's hard to beat the ACDF. I am at the home of the ACDF. You should know, Percival Bailey was the first chair at the University of Chicago. He was one of the early trainees of Harvey Cushing. He trained Earl Walker. He trained Paul Busey. He went on to train 20 chairs, including the chairs who went on to the Brigham and other hospitals. He actually trained more chairs than Harvey Cushing did. And he wrote the book on the classification of brain tumors. He did so many things and was really a pioneer in our field of neurosurgery. And a few chairs after him was Ralph Cloward, and Ralph Cloward invented the ACDF, and so I am at the home of the ACDF, and many of you still use Cloward instruments, of course, and these are very common. And the ACDF is a great procedure that I offer routinely, but it's hard to beat the ACDF. It's a procedure with a 90 to 95% patient satisfaction rate. There are very few procedures in spinal neurosurgery that have that. And yet, the arthroplasty has been shown to be as good or slightly better in certain patient populations. And it's very hard to beat something that's 95% effective. And it's done it through clinical trials and through a series of them. It's not one or two anymore, it's many clinical trials. This now lumbar arthroplasty is a different story. We can talk about that later, but cervical arthroplasty certainly. So this is a patient with lumbar stenosis without mechanical pain, and it's a 54-year-old with claudication. So look, there's a lot of arthritis. There's many approaches that you could do for this kind of case. You could do a multi-level fusion, you could do a multi-level decompression, many different approaches. But to me, this is a patient where you don't have mechanical back pain and the symptoms are clauditory. And so when that's the case, I think a decompression functions very well. And for these two levels, you can do two tubes. You could be with loops, your assistant could be under the scope. You're looking up, looking at the scope, and it can be very effective. And of course, you can reach all the way to the other side. You can see my tube at the upper level where I'm able to reach all the way to the contralateral side. In many ways, you can see better contralaterally than you can ipsilaterally. And so, very effective surgery and procedure from that standpoint. This is a 51-year-old male who had a wiring procedure, which was done many decades prior and which fused, by the way. And so this fused without instrumentation, with wiring alone. And you know, the fusion rate was not zero on wiring, by the way. You still had, you know, a 70% fusion rate, according to many articles in literature. Of course, screws took that much higher, BMP took that higher, you know, all of those things, but you still had a robust a robust solution with when it came to wiring. And so this is a 51-year-old male who had a prior wiring, has adjacent segment disease now. And so this is a case where I like to offer a percutaneous fusion. And so you can see my screws. You can also see how with the indirect decompression, I'm going to show you what the indirect decompression does foraminally and centrally. You can see here how the indirect decompression has changed the nature of the foramen and has expanded the foramen in a significant way. And then I'll show you how the indirect central decompression, you know, people look at this, they say, oh, was there a laminectomy? Was there a central? There was not. And so this is all based off of indirect decompression. Foraminally, it works. Centrally, it works. It's effective. And it's something that can be offered. This is a high-grade spondylolisthesis in a 21-year-old male. And you can see here, you know, this is a case that traditionally I would have done, I think many people would do as a front back. And then posteriorly, depending on how well it comes back, potentially going up to L4 or down to pelvis. And so, but in this case, as I looked at it, analyzed it, assessed it, I thought, okay, are there minimally invasive techniques for this? And I've done about 15 cases like this now, and I really like the minimally invasive approach for these cases. And so here I start off with K-wires. I place 4 percutaneous screws. By the way, with reduction heads. So I use the heavy reduction heads that can provide 25 millimeters to 30 millimeters of reduction. And then I proceed to put 2 drills bilaterally into the partial fascectomies, 2 drills bilaterally, all done in a percutaneous manner, 2 drills bilaterally into the disc space. And then I have monitoring all at the same time. And then I'm able to pull back and start using my drills. And you can see already how it's reducing generally with this degree of spondylolisthesis. You know, my goal is not 100% reduction because you do start to see L5 palsies and paresis resulting from that. And so, but again, you know, I have monitoring throughout for that reason. And then you could see here, my 2 drills are in, my 4 screws are in. I've put in rods and I've already started the reduction, right? Um, and so you can see there intraop fluoroscopy. So now I'm pretty pleased with where this is heading and pretty pleased with how much I've been able to reduce this. And so, you know, checking with the monitoring, the nerve is fine and safe. And so, you know, we leave well enough alone. And so you can see the pre-op on the left and the post-op on the right, and you can see the AP on the furthest right. And so you get a nice reduction. It takes about 120 minutes. Patient generally goes home, if not that day, the next morning. And so it offers a significant advantage over traditional front back for this kind of surgery. I'll tell you a little bit about robotics in spine surgery. Robotics offers many advantages. smaller incision, reduction in complications, less exposure to radiation, shorter length of stay. There's a disadvantage, of course, the cost of the equipment, the learning curve, which is significant. This is a 53-year-old female with an L5 radic and a grade 1 L4-5 spondylolisthesis, failed non-operative measures, all those things. L4-5 TLIF, left-sided approach is what I want to offer in a robotic percutaneous manner. And so first I start with my thin cut CT, and that's my OR on the right. And so you can see how I set up my OR, how I set up all of my instrumentation in there. Um, and then I start by placing a Shands pin. And that goes into the mid third of the sacrum, just lateral to the SI joint. I lock it in to the arm at a right angle. I take a blue surgical towel over the region of interest. Um, I register the camera. I take a passive planar probe to estimate the levels. That's me holding it there. I take a target extender to attach the robotic arm. Take 2D fluoroscopy images to combine them with a pre-op CT. I mark my skin incisions, and that's what the skin incisions will look like. And so again, as a basic principle relative to what I was telling you earlier, in terms of the multifidus ligament, in terms of preserving those midline ligaments, this is a paramedian approach altogether, which promotes healing. I insert the K-wire into my L4-5 disc space. I confirm on fluoroscopy. You can see my level of spondylolisthesis. You could also see my K-wire that's in there. And at the very bottom, that's the pin that I put in at the beginning. And then my screw placement, which is the left L4 pedicle, a stab incision, and then a cannulated dilator. And then I place a drill guide through the cannula. I have screw placement into the left L4 pedicle, and I insert a 3 mm drill. I tap the pedicle over the pilot hole using a 5.5 mm tap. I verify the bony integrity, and the screw is placed in the tapped hole. All my screws are placed in a similar fashion. And so you can see here, and you can also see the four screws have been placed. You can see that the blood loss is negligible. And then what I do is I place sequential tubular dilators until I reach an 8 mm tube. And then I proceed with a percutaneous discectomy at that point. And then my interbody device placement with my four screws, placement of rods, final tightening of my screws. And that's kind of the procedure. And I published the initiation of a robotic program in spinal surgery. And I published results around this. And the results generally were very favorable with low blood loss, positive outcomes, low revisions, which were really intraoperative, not postoperative. Operative time went down over time. Utilization frequency went up over time. Fluoroscopy went down. And so all of those things were positive. And here's another example, like in this case, a 63-year-old female and who needed a multi-level fusion. In this case, I did robotic instrumentation, all done and completed. And you design beforehand what you want these to look like so you can deliver the outcome that you've designed. And so I'll tell you the future of robotic spine surgery and then happy to take questions. There's, future applications, which would include, use of artificial intelligence, augmented reality, robot-assisted drilling, automated rod bending. And so happy to take any questions that people may have.
Thank you very much, sir. That's amazing for you, sir. I believe that this was a very insightful talk, and I do think there are a few questions that come into my mind as well. That you've noted that every robotic screw tack retains a distinct sky potential of the curved bony anatomy, requiring a surgeon to have an intuitive, open tactile feel to troubleshoot it. Given that current platforms lack the true real-time haptic feedback, do you see the solution to the sky bottleneck coming from automated active drilling feedback loops like the reinforcement learning tracking bone density changes, or from a fundamental shift in how we design our initial percutaneous docking trajectories. So how do you think that that could be addressed in robotics?
Yeah, I mean the haptic feedback's important to me, and I feel the skives now, having done so many of these cases. But I understand that someone who hasn't wouldn't necessarily feel those. I think MIS, it's hard, right? Because you don't have the direct visualization, and and that's why all of your senses become so important when we're doing like a percutaneous discectomy and decortication. I always tell it, like my trainees and co-surgeons, I say, well, you really have to listen to that decortication of the end plates, and you hear it, and you hear it as it's occurring, and you feel it. And there's a feel of when you're decorticating, when you're not breaking too much, or when you're, um, and so all of your senses become very important. You can feel, I mean, when you're doing an open surgery, um, you can feel a skive. I mean, you're looking at it, but you can feel a skive. Even if you weren't looking at it, you could feel that you skived. Now, with the robot, I think people have a lot of trust in the system, maybe in a misplaced manner. And so I would remain very diligent around the importance of skive. I think your x-rays become really important as well. I always like to take a K-wire and feel, so that I still use a feeler, even though it's robotic. And so people say, oh, there's no feeler. And so, and the companies now actually teach my technique for that. Um, and so I think those become really important. But the principles, I mean, and this is something really important. You cannot skip the open. I trained in a program at Johns Hopkins, which was very heavily open with Dr. Zia Gokaslan. We published actually open instrumentation, anatomically guided with X-ray afterwards, not even fluoro guided, with a 94% accuracy rate. And so we published that very carefully. I think you really have to know and understand open surgery, because if you don't understand that, adding technologies will not get you out of trouble. It just further, actually, it further hastens the likelihood of getting into trouble. Um, and so, I think those are yeah. So those would be my comments on that. But I think it's a great question. And I see a couple of comments. If you don't mind, I can address those in the
Sure,
chat.
sure, sir.
Yeah.
That's great.
So one comment from Dr. Harshad is complications and dural tears. There can be complications, of course, in all surgeries, and there can be dural tears in all surgeries. And so I think those are important complications to think about and to understand. Verification of placement, verification of instrumentation, all of those things become really important. The monitoring becomes important. Um, if I'm doing a T10 to pelvis, that my intraoperative neuromonitoring team, doesn't question the need for neuromonitoring. But if I'm doing, a single level robotic T-lift, they say, oh, do you really need it? Well, I don't see anything. I have no visualization. So yes, I do need it, because other than feel, sense, X-rays and neuromonitoring, I need the feedback. And so I think the feedback becomes really important, when those new technologies come into the mix. And then Dr. Abid's question around MIS deformity correction, I think that's increasingly occurring, particularly with lateral approaches, followed by posterior instrumentation. And then osteotomies, the newest platforms, do perform osteotomies, and do perform facetectomies. And so those are platforms that perform those things and that enable those things to occur and things that are, important for us to recognize, obviously. So.
Sir, also there is a question in my mind that a major advancement utilizing the advanced MIS corridors, such as the prone trans-source approach, is the elimination of the time-consuming and logistically risky intraoperative patient flip. However, if we are performing an anterolateral or oblique interbody fusion while the patient is prone, it may introduce unique structural shift at the target coordinates dynamically change during the cage distraction. So how do you leverage robotic navigation and active trajectory planning to overcome these shifting landmarks in a single position surgery? And do you find that the automated workflow entirely mitigates the steep learning curve traditionally associated with these blind lateral corridors? I again agree that it basically depends on a surgeon's own experience and expertise. Like you have very nicely mentioned that robots are just your assistants, and it depends on your own expertise. But how do you think that it could help in like the prone transverse approach?
Right, right. So due to patient shift, I like to do the instrumentation first rather than the inner body first, for that very reason. And I do think that prone transpsoas is a good approach. I don't think that lateral and then intraoperative repositioning is I don't view that as risky personally. I think the people who do it have it down to something very quick, and within 20 minutes they're starting the posterior. I would say, and I often tell my patients, the best surgery is the one that your surgeon is most facile at. There is a big learning curve with any new technique, new approach. If you're delivering the surgeries well and at a good volume and with outcomes that you're happy with, I think then that's a good surgery and you're doing a good job there. And so those are, important areas to pay attention to. And so I think all of that, becomes really important, and all of that becomes, important to recognize, especially when you're taking on a new technology, that there is a big learning curve, and that it may not be the right technique for you. There might be other techniques that you're so facile at, and that'll be the technique that you offer. And so, and then in terms of the question from Dr. Harshad, have I converted to open? If so, why? I have. It's infrequent. Today, the last 2 years, I can't really think of a case. But I've been on this journey, since 2015. And in the early years, there were many open conversions. Just the technology wasn't as good, the software wasn't as good, things didn't feel right. I always tell them putting in a screw should feel like putting in a screw. Okay, just because you're doing it minimally invasively, that should feel no different than open. And if it doesn't feel right, then don't put it in. Take it out, look, x-ray, and if it doesn't make sense, convert to open. And so all of those basic principles, I early on I didn't hesitate, and probably my conversion rates in those very early years, you know, 20%, 10 every 10 cases, I would convert one or two. And so, but that's become much less frequent for me. A, as the systems have gotten better. B, as my own workflow has become much more standardized. I know I'm going to take 1,000 steps and I'm going to do them the same way each time. And that just comes with doing a lot of them and recognizing a workflow and having a consistent team who all know that that's going to be the workflow today.
That's amazing, sir. Sir, I believe that don't have any more questions. So you also have a lot of amazing work on spinal, on stem cells for spinal surgery, and that's also a very interesting topic that I really wish to you to deliver a talk if you have if it is convenient for you in the future, because it's something of great interest. I think in John Hopkins, basically, Dr. I invited Professor Theodore, and he delivered something on that as well, and it's a great work as well. So how do you think about that? What's your opinion about stem cell therapy
Yeah,
in
no,
general?
thank you. I think it's, part of the reason that I wanted to come to a university like the University of Chicago is I believe that to make the big leaps in medical advancements, you have to be part of a robust university. And I see that as I'm here daily. I have 20,000 students on this campus. So I get people that come in to my lab routinely. There's no struggle to recruit. It's very easy to recruit and get people. And that enables the work to occur faster and at a more significant pace. And there's a reason, that at a place like this, we have 100 Nobel Prizes, because it's just a very strong intellectual environment of pushing the field forward. I think stem cells are things that push the field forward. And specifically, in my case, using them for paralysis, I brought my whole lab here with me, 25 people. We've had several offshoots of that lab now occur. And very successfully, we're starting our next phase of trials. And so our next phase of trials will be called NeuroRise. And those are starting. We just got FDA approval, actually. And so it's a very exciting moment in neurosurgery and regeneration. I recently hired a brain tumor surgeon, Dr. Comer from Johns Hopkins, who is the lead, brain tumor and epilepsy surgeon. And he's a world famous person. And he is a believer in neuroplasticity in adults. And you see that sometimes, right? And so you see that when you're doing tumors, if you have like a melanotic schwannoma and the whole nerve's got to go and the patient's older, and you take out the whole nerve and you say you will have a foot drop. And so often they do, but not infrequently they don't. Or if they do, it's so mild, or it's 20%, and then you see them 6 weeks later and it's like almost full strength, 95%. How does that happen? And so yes, there's multiple contributions. I get it. But then one would still expect a 30% reduction. And you don't always have, sometimes you do, but you don't always have that. Or if there's a reduction, it comes back, or people have a stroke, they get better, or so anyway, so there is a plasticity that occurs. Plasticity isn't just something that occurs, in a dish or an animal study, or there is plasticity that occurs even in the adult, even in the older adult. And so all of that, harnesses our obligation to evaluate that process, the mechanisms around that process, and how to upregulate that process. And so I think that's a really exciting question to me, mechanistically and therapeutically. And I'm very committed and dedicated to that area, and have hired actually several people. So I've been at the University of Chicago for a year. I've hired 10 neurosurgeons in that year, but I've also hired five PhD lab investigators, principal investigators, not postdocs. And so those people have brought laboratories, including in areas like this, so that we can tackle problems like this, and be leaders in this area for our specialty and for our patients.
And sir, in recent years, we are understanding more about tumors, and we do believe that tumors actually interact with the surrounding cells, including, the glial cells and everything. For brain tumors, like in glioblastoma, now the researchers are introducing that there was connectivity, that basically even to, these astrocytomas are actually communicating dynamic ecosystems, and they usually can communicate with their neighboring cells, and they induct all their environment by the cells. So maybe sometimes this is important, like in brain. I've seen that in low grade glioma, sometimes plasticity is already there, and some of the centers actually shift. And it sometimes make the plasticity theory along with the connectomics theory in brain usually collides, and they just think about the subcortical pathways and the cortical center, the hub and nodes and networks and everything. So all these connectivities, I think this is a very important question, like you have very nicely mentioned, that it's we need to think about it, take it to a different actually like a different issue. So I think that it's very important to think about that environment in where the injury has taken place. But sir, also for stem cell, we always think about how they can actually differentiate. And sometimes people say that if we take the factory stem cells, those will be more helpful in neurological injury, because the factory epithelium has that type of the potential to differentiate into neurological injury. But there were cases that it turned into a mass itself, it turned into a tumor. So how do you think that we can actually enhance the communication of these stem cells, and how can we actually modulate the environment into inducting those stem cells into integration? And how can we, like, yes, you have already working on how you can actually induce plasticity in spinal cord as well, because plasticity is a very huge concept.
Well, with the stem cells, a lot of times it's not about their direct ability to differentiate into neural cells. Rather, it's about the cytokine environment and milieu that they create for the existing cells that are in that area that enhance their own functionality and perhaps even blood vessels to them. And so then, what I would say in terms of brain tumors, you're absolutely right that there's connectivity across the board. Um, uh, Glia connect in various ways. This is the home of synaptic connections. That was one of the Nobel Prizes.
Okay.
Um, we have one of our neurobiologists today who is mapping the entire connectome, which is 4 quadrillion connections. It's either 3 or 4. I forget, which is a huge difference, by the way. That's not like 3 quadrillion versus 4 quadrillion. It sounds like it's
What is
only three
that?
or four, but it's a huge difference between
What
them,
is that?
um, because it's quadzillion. And
Yeah,
so,
countries are very big.
yes, yeah, the number of
That's
connections is
okay.
very high.
That's
Tra well, and I think this is where tractography, I think, is a very tractography does not give us a great idea of what's happening. Tractography also is very subjective. Tractography assumes that the different pixels on an MRI have meaning. Tractography is inaccurate.
Yeah.
As soon as you get into the dura, boom, now it's inaccurate. So, so there's a lot of elements there, like so many people plan their surgeries around tractography, and that's fine in the, primary motor, primary speech. But then, the definitions around tractography, personally, I do not view that as the future. Um, I view it as a temporary field of study um, that makes a lot of assumptions and is highly subjective. Um, and and is just reflective. And this is what I was telling our neurobiologists of the fact that we don't understand the quadrillions of connectomes. And
Yeah.
that's why we've turned to things like MRI pixelation as though that has a meaning. So as we learn more about the brain, about the central nervous system, about how our brain cells connect and speak to one another, we will have more detailed therapies and more targeted therapies for our patients than we do today.
And also the mode of treatment will change, because from cytocytal, like in the case of glioblastoma, again I'm quoting because I've just read a paper on it. But sir, instead of just addressing a mass, we are also addressing the environment where the mass is, and how we can actually, the connection, how can we disconnect those things or modulate those connections or reprogram the cells, because there is a recent report where they actually were able to reprogram the cells, and they just forgot that they are like, they differentiated into better, into non-malignant or as less malignant variety, and that was a very joint leap, because the tumor was there, but the new cells were getting a little more differentiated in the previous one, and they said that it's very, very successful. It's a preclinical trial, but still it is successful.
Which
So the
shows
last,
you that plasticity occurs. I mean, tumors are an example of
yes,
plasticity, which
yes.
shows you that it's not, these cells change and adjust. And as we map the connections, my guess is we're going to see that these are far more robust and resilient than we ever imagined.
Yes, exactly. And so that's why, that there's a lot of hope in this area as well. And sir, last question. I think we have taken a lot of your time. Sir, you have got extensive work in disk genomics and proteomics as well at the neuroinformatics laboratory. So there's always a classic, the chicken and egg debate on whether the disk is the primary driver or simply the mechanical victim of paraspinal muscle or ligamentous failure. So, what you and your team isolate as specific proteomics or RNA profile predictive of rapid multi-level hydration loss in especially the young patients? And do you envision that it could lead to an early stage molecular therapeutics, or will it primarily serve as a predictive risk stratification tool to steer high-risk genetic cohorts away from fusion and towards motion preservation strategies early on? So I believe, sir, this is something of great interest in research, the dysproteomics and genomics. So how do you see that, sir?
Sure, sure. No, and I'll be happy to address Dr. Faruqi's question about high-grade spondylolisthesis, putting in screws at L4 also. Today I generally don't do that unless I feel like the L5 screws won't hold. But historically, I've done a lot of, L4 to S1, L4 to pelvis, depending on how high grade it is. I think it probably depends on the patient, on the particular case, but I think that's definitely a useful strategy. And then in terms of disc genomics, I think it's an important area. Discs are hard to work with. The RNA is very fragile. They're very acellular. They're very acellular. Hard to preserve them. It's unclear which of the genes. I mean, we've narrowed the genes down. We've published in Gene on this topic. We've narrowed the genes down, but it's then you have to jump to like what gene therapies. And so I think it's a promising area of research. Back pain is the number one cause of disability in the United States. Neck pain is number three. Headaches are number two, by the way. And so it's a very important topic and area. It's one that we'll continue to pursue. Um, I think the current RNA extraction technologies for us leave a lot to be desired when it comes to something as acellular as disk material. Um, but having said that, I think it's a good thing for us to think through and discuss and all of that. So,
Thank you very, very much, sir. I think we have taken a lot of your time today. Thank you very
sure.
much for sparing
My
time for
pleasure.
this very insightful talk, because we went beyond your talk. I just had a few questions that were very exciting for me. Thank you very, very, very much, sir.
My
It was an
pleasure.
honor to welcome you. So thank you so much. It's an honor for me and for all for everyone who's attending this talk, sir. Thank you very much. All of your topics are very very striking, and I hope that they will be really beneficial for the patients in the years to come. So thank you so
Pleasure to
much,
be
sir.
with you. Thank you very much. Bye
Thank you
bye.
very much. Thank you very much, sir.